Good afternoon, everyone, and welcome to the next session. My name is Paul Chiam from Singapore, and my co-moderator today is Dr. Oh Jun Hong. And we have a distinguished set of panelists here: James Flaherty from USA on the right side, and Oh Song Kwong and Yonggu Lee on my left-hand side. So I think let's start with the first case. So Junhong Lee is going to present a case of a transcatheter aortic valve implantation using a balloon self-expandable device for treatment of failing self-expanding transcatheter heart valves.
Good afternoon. I'm Jung-Eun Lee from Eunpyeong St. Mary Hospital. I'm very pleased to have an opportunity for case presentation at AP Valve 2022. The case what I prepared is about acute failing of self-expandable valve treated with balloon expandable device. I don't have any potential conflict of interest. 76 years old female come to emergency department for dyspnea on exertion. She underwent a TAVI with 26 millimeter size self-expandable valve for degenerative severe aortic stenosis at 6 years ago. She also had a history of hypertension and peripheral artery disease. STS score is intermediate to high risk group. ECG showed the normal sinus rhythm. At the emergency department, the simple chest X-ray showed the cardiomegaly and pulmonary congestion. And then the findings of mild anemia and increased BNP and respiratory eclampsia was shown at initial lab findings. And this is transthoracic echocardiogram, which was performed at ER, showed severe aortic regurgitation originating from the inside the biostatic valve strut. LV size was normal, suggesting acute stage of regurgitation. In TEE, the flame motion of the NCC and tearing of LCC was observed. Severe aortic regurgitation jet was observed through the leaflet. RCC was relatively well functioning. When he performed the CT, there was no vegetation or penis formation. Like echocardiogram, CT showed the failure of non-coronary cusp and left coronary cusp. So we analyzed the CT for further treatment. Inner area and perimeter of new annulus were 375 millimeter square and 68.9 millimeter, appropriate for 26 millimeter size self-expandable valve or 23 for balloon expandable valve. However, when we measured the sinus of valsalva, the area is too small and it strongly affects the coronary obstruction. There is no problem at LVOT level. Coronary height is 12 millimeter and ICA was 14.5 millimeter. The main problem is the risk of coronary obstruction. This illustration is published from JACC Intervention in 2020. The first TAV, red color, the first TAV leaflet could seal the sinus of valsalva all around and resulting in coronary obstruction. So to avoid this, first TAV commission level should be lower than STJ from inflow level. The second, distance between TAV and STJ it should be longer than 2 millimeter. This previous self-expandable valve commercial height is 26 millimeter. And this balloon expandable valve, we are planning to use 23 millimeter. The left side is an example of a high-risk coronary obstruction. You can see the lower STJ level compared with the first TAV commercial level and the short distance between TAV and STJ. The right side is our case. It's compared with the left, much lower than example, which means the very high risk of coronary obstruction. Peripheral anatomy is fine. First discussion point. Major discussion point is maybe surgical approach or TAVI. This patient already underwent a TAVI 6 years ago and didn't want a surgery. Next is how can you overcome the risk of sinus sequestration? In this case, the main problem is the tearing of a previous valve leaflet. There is no limitations of flow without thickness, so we focus on the treating aortic regurgitation. Figure on the left is ideal position of a balloon expandable valve in valve, but we couldn't do because coronary obstruction risk. So we plan to implant at the low level below the bottom line of the first THV to avoid the overlap between second valve frame and SDJ. Lower implantation could stop the regurgitation without limiting flow because the prior TH valve was torn without thickening. And this is our planning. We checked aortograph and coronary artery levels again with contrast fluoroscope. This is not an usual case, usual situation, so we tried to find proper position several times again, and finally we implanted. After successful implantation, there is no regurgitation flow. We changed to the diagnostic catheter to find coronary arteries. The right is here, and the left is here. After 1 month, the patient came to our clinic again, and symptoms were totally improved, and chest X-ray showed a decreased pulmonary vascularity. Echocardiograph showed mild elevation of aortic valve velocity and mean pressure gradient compared to previous finding. Only trivial leak was shown. The concern is the longevity or durability of a THV, which one affect the patient, previous one or current one, and the strategy of index TAVR to reduce coronary obstruction for future valve-in-valve TAVR. Thank you for listening. Thank you.
So we got a couple of minutes. Any questions from the panel or from the audience? Oh, it's gone now already. Maybe you can just take one question or something. You have a question?
Question to Dr. Lee.
Yes.
Yeah. I have one question. Thank you for your nice and wonderful case presentation and the result. You said that she underwent TAVR 6 years ago, but unfortunately, her valve deteriorated and resulting in the massive aortic regurgitation. So, do you think what was the etiology to deteriorate the valve, and then what contributor should be considered in next step, sub or TAVR, or other than sinus sequestration?
The first question is we don't know. We exactly don't know the etiology of the valve tear. Maybe it's just is not for valve durability. So we don't know because the previous valve was not thick and only tear at the LCC portion. So that is nobody knows. And second is a very important question for the sinus sequestration. So to avoid this, we first time we planned to the surgical AVR first, but patient denied to have underwent a surgery, and so we should check in first TAVI for further sinus sequestration. So we should choose the proper valve in further TAVI valve.
May I have a question? Okay, now let's move to the next case, titled with transcatheter tricuspid valve in ring and large serve mitral LV pseudoaneurysm closure with the ampular vascular plug 2 in a post-operative patient with a pacemaker lead. Dr. Thinakrit Sasiprahara from Thailand, please.
Good afternoon, panelists and moderator and audience. I'm Thinakrit Sasiprahara from Rama Tripedi Hospital. I am an interventional cardiologist here. Today, on behalf of the team, I will present you addressing case 1. Okay, I have nothing to disclose here. So without further ado, let's get into the case. We have a 73-year-old woman who had been diagnosed with severe mitral regurgitation 5 years ago. And at that time, she had received a surgery of mitral valve repair with ring, and you can see in the chest, it's right here. And at that time, she developed a 6 syndrome and receiving a single chamber permanent pacemaker too. And 1 year ago, the patient had a recurrence of symptom of dyspnea exertion. The chest rate showed cardiomegaly and congestion, a live fusion. You can see in chest X-ray. The echo showed a recurrent severe mitral regurgitation, and also now she also have a severe tricuspid regurgitation too. So the surgeon admitted the patient to do a mini mitral valve repair with EPICS bioprosthesis valve size 25 mm and tricuspid valve repair with a contour 3D annuloplasty ring size 28 mm. Unfortunately, during a post-operative period, the patient developed a right hemothorax, ventricular associated pneumonia, and acute kidney injury. So the patient had a prolonged admission. And a month after surgery, the patient admitted. During admission, the patient developed a recurrent heart failure now, and you can see in the echo in the screen that the good function of the bioprosthesis valve in the mitral area, but there is recurrent severe TR even after a month of surgery. But if you look closely in the left in the left screen, you can see that there is some trivial or minus of aliasing flow at the posterior commissure. This is an abnormal thing that we noticed at that time. So we moved the patient to the cath lab and do the left and right heart catheterization. And it revealed that it increased of LV and diastolic pressure and also of wet pressure. Then we do the left ventriculogram here. As you can see, there is large of abnormal chamber connected to the left ventricle here in both RAO and RO view. That time we suspected of a left aneurysm or pseudoaneurysm here, and then we sent the patient to the CT scan, and it revealed submitral pseudoaneurysm size 2.5, 4.9, and 4.1 in diameters, in centimeters, and the next is 0.77 centimeter here. And as you can see in the tunnel from the left ventricle to the aneurysm. At that time, we think that this aneurysm might cause increase LV-EDP because it acts like a dead space for the left ventricle. During systole, the blood go from the left ventricle into this area, and the diastole back upward to the left ventricle is increase of the ventricular demand. So now we have two problems. First is submitral LV pseudoaneurysm, and the second thing is recurrent severe TR. The patient denied any surgery, and we bring the case to the heart team. The surgeon turned down the surgery too. Then we have to do these two operations. Then we decide to do in skip in both in the stepwise pattern. First, we try to close the pseudoaneurysm first, and second, we try to do a TARBI in ring in the second operation. Firstly, we did a submitral ablation with JR guiding catheter 6 French here, with the TE guided and assisted with a Churamo guide wire, and we easily and luckily can pass the JR guiding catheter into the aneurysm here, as you can see. And the injection confirmed the intraclavically in the aneurysm of the JR catheter. And the TE confirmed again the JR is in the submitral pseudoaneurysm here, and this is the neck of the pseudoaneurysm. And the size is about 0.8 centimeters. So we decided to deploy the ABP2 or plaster vascular puncture in this area. And then during deployment, we use the guiding catheter there, and we deploy the first lead here, and we peel back, and then we deploy the second and the third disc, and push into the tunnel at this manner. And the following left ventricle can show the complete occlusion of the pseudoaneurysm neck here. And we have finished the job because we have to treat tricuspid regurgitation too in this case. So we have an image of IO to check the deployment angle. And you can see this control 3D annuloplasty ring have a S-curve in the lateral view. It's not that like a coplanar view because it have a to curve along the tricuspid annulus. So it's quite challenging to do the TARF in ring in this case. For the valve information, for 78 millimeter, this is inner diameter of 78 millimeter too, but for in the CT scan, in this case, it's about 26.8 millimeter. And then we decide to use Sapien size 26 S3 for TARF in ring. Firstly, we put the balloon bed pressure into the left pulmonary artery, and then we switch into the plus superstipary. First, we have to try to dilate the balloon first to check the balloon orientation according to the balloon orientation interaction to the valve ring, because if it slip into this incomplete ring area, it might catastrophic. So after we deploy, the position quite okay. Then we proceed to the S3 deployment. Here we pass the S3 into the IVC and preparation as usual, and then we put into the positioning into the valve in ring in this position, about a marker to marker, and about 15% to the atrial side. And during deployment, we use a self-fully wide in LV for pacing because we avoid the interaction from the pacemaker and the rise and the S3 in this case. So during deployment, we have to switch to LAO and RAO and to check the position and to adjust the position, not let the valve pop out into this area. And then after the deployment, this is a final scene after we deploy, and this is acceptable position, and there's some hole which because this is we expect that the ring is not circular, structure, so there's some hole between the S3 and the ring, but the thoracic echo showed just mild to moderate parabola leak, and the mean pressure gradient of about 4 millimeter. And we did on right ventriculogram too, then it's just mild to moderate parabola leak. So we have to stop the procedure at that time. And the patient get better after we did these two operations, and we can discharge her home after a long period of admission, about 2 or 3 months within the 2 weeks. And the patient still follow up now today. And this is a discussion points for you. Our first is the strategy for pseudoaneurysm closure in this case. What would you do and what device would you choose? And the second is further management for residual parabola leak after, in this case, would you do it again with the device closure, or you just conservative as what we do? So let me conclude about my case. This is a submitral AV pseudoaneurysm case. It's a rare complication after mitral valve surgery, but potentially leads to the major events. The second is the transcatheter pseudoaneurysm is feasible, and the TARF in ring intervention in tricuspid area is an alternative for recurrent severe TR patients. Thank you for your attention.
Very nice and fantastic case presentation. Maybe we have 1 or 2 questions on this case. Do you have any comment on question?
May I have a question?
Excellent presentation. You know, these valve in rings in the tricuspid side are very challenging because of the three-dimensional shape of the ring. Do you think there has to be a different valve to solve this problem, or Do the surgeons have to change their technique to allow a transcatheter option?
I think there is
Should have
no in this nowadays valve we have I think that no more fitable valve to do in this ring area because it's not a circular area. But maybe we have to do something that we can push the valve into the true or the more correct area in the ring. Yeah, that's what we thought.
My question is how to choose the sizes of those devices. One is plug and one is sapien valve for tricuspid valve. How to choose the size?
size-
What percentage oversizing or something?
We have actually we use the application for mitral valve involved. It's also now that it's in the tricuspid in ring 2. So we use it according to the application, and the second is the measurement from the CT scan. We try not to over dilate the valve because if it over that, it can pop into the incomplete area of the tricuspid ring. As it might, at least 2 or 3 cases reported that had the patient to have to do the surgery after they do and trough in ring because of over dilatation of the valve.
I have one simple question. You successfully put the implant device for the pseudo aneurysm. So, do you have any available data of the long-term results or outcomes after the device closing in intracardiac pseudo aneurysm?
That's a very good question. Before we do this operation, we have searched for many case report or case history. There's no long term. There's no long. The most long term data is about 2 or 3 years, not more than
3
that.
years.
But I think, but this AVP2 is more suitable for this case because it's tunnel-like lesion, and the next was small, not that big. And if we use an ASD device or something like that, it may entangle to the valve, aortic valve or mitral valve. So we use an AVP2 plug.
Excellent. Thank you.
Thank you very much.
Okay, thank you very much.
Yeah. So let's move on to the next case, which is coming from Christina from the Philippine Heart Center. She's going to present a case of a cryptogenic stroke, presenting with seizures in a 24-year-old Filipino female due to a PFO.
In challenging circumstances, in the face of uncertainties, we find answers to explain the hows and whys. I am Christina Tabucan, a third-year adult cardiology fellow in training from Philippine Heart Center, and I will be presenting a cryptogenic stroke presenting with seizures in a 24-year-old Filipino female, a case of patent foramen ovale. I have no actual or potential conflict of interest in relation to this presentation. And these are my discussion points. To present a case of a 24-year-old female with patent foramen ovale who presented with recurrent seizures, and to discuss how transcranial duplex ultrasound can still be used as a confirmatory imaging, especially in patients who cannot tolerate transesophageal echocardiogram, and to discuss the approach of management based on the available guidelines. So we are presented with a case of a 24-year-old female who came in with a chief complaint of left-sided weakness, who had unremarkable anamnesis at birth. However, at the age of 5, her mother noticed that the patient had noticeable easy fatigability, causing the patient to be less engaged to activities of her age. It was also reported that the patient experienced recurrent exertional dyspnea, which prompted her parents to seek consult to a pediatrician. Workups were done, and that patient was diagnosed with congenital heart disease, valvular severe pulmonary stenosis, supravalvular membrane with post-stenotic dilatation. She underwent balloon valvotomy and noted on repeat transthoracic echocardiogram residual moderate pulmonary stenosis with 2 small atrial septal defect, each measuring 0.4 centimeter and 0.5 centimeter with left to right shunting. They were advised to follow up. However, because of financial constraints, they were unable to do so. The patient improved. However, she did not come back until 5 years prior to consult. This patient had recurrence of easy fatigability. She experienced recurrent severe migraine attacks that prompted again to seek medical consult. At that time, she underwent transthoracic 2D echocardiogram, where a small atrial septal defect was considered. She was advised to undergo transesophageal echocardiogram to further interrogate the lesion. However, during the procedure, they had to abort the TEE because the patient went into seizure. She was advised to follow up. However, because of the apprehension due to the noted seizure, she again lost to follow up. Until 4 years prior to consult, the patient had left-sided body weakness, which lasted less than 5 minutes. At that time, she had recurrence of the seizure, and she noted that there was migraine prior. She only self-medicated with analgesics with no consult. Until 5 days prior, she had recurrence of the symptoms, and there was left-sided body weakness less than 10 minutes associated with headache, prompting her to seek consult at our emergency department. So upon arrival at the emergency room, she was stable with blood pressure noted at 100 over 60 millimeter mercury. The oxygen saturation taken on peripherals were 98% on room air. She had residual circumoral cyanosis. She had the dynamic precordium with no palpable heaves or thrills. On neurologic examination, she was awake, conversant, and oriented. GCS 15 E4 V5 M6 with no neurologic nor cranial deficits noted. The motor strength was 5 over 5 with sensory of 100 in all extremities. However, this patient was highly considered of prior stroke and stroke in the young due a probable paradoxic embolism given her age and premorbid congenital anomaly. What we did, we had a rope score to this patient and what's noted at 8 points. And this was be used to identify the probability of a paradoxic emboli that may be secondary to a patent foramen ovale. Thereafter, we requested for diagnostics. The chest radiograph was within normal size, and it was unremarkable. There were no chamber enlargement, nor carinal splaying, and the lungs were clear. And then the ECG was noted in sinus rhythm. And as this patient had neurologic deficit prior to consult, we requested for a plain cranial CT scan. Ideally, an MRI should have been requested in this patient. However, at that time of her consult, it was not available in our institution. Following the guidelines, contrast-enhanced transesophageal echocardiography combined with standard Valsalva maneuver was the reference standard to detect the PFO, primarily because of its high specificity. What we did is that we had a 2D echocardiogram, and we did follow-up of transesophageal echocardiogram. However, upon advancement of the probe, the patient had again recurrence of the seizures. Hence, we were not able to complete the study. We only had the clips. And to supplement and establish a diagnosis, what we did is that we had to undergo this patient for a transcranial duplex ultrasound to measure the blood velocity profile across the cerebral arteries and to identify and confirm the presence of PFO. We have infused in agitated saline to create microbubbles injected at rest and during Valsalva to increase the flow into the lesion that would briefly alter the interatrial left to right pressure ratio. And we have confirmed that this is a patent foramen ovale, which showed a grade 5 right to left shunt post-infusion, and noting as well disruption of the vessel of interest, indicating the presence of microbubbles. Paradoxical embolism that occurs whenever venous blood crosses the PFO into arterial system that bypasses the pulmonary circulation would allow this to cause cryptogenic stroke. So these are the clips that we did after confirming the diagnosis. What we did is we closed the PFO using the occluder device applats, and we had the injection of the dye to confirm the placement of the occluder. In summary, what we have discussed, we presented a female, young at her age, who presented stroke symptoms with recurrent migraine attacks and seizures. Rope score of 8 based on the SCAI guidelines, PFO, recommendation of rope score of more than 7 that identifies patients who would likely benefit for patent foramen ovale closure. Echocardiogram was done to a certain diagnosis. However, given the gold standard to do transesophageal echocardiogram, this patient was intolerant. We had to supplement the diagnosis using the transcranial Doppler ultrasound to identify the probability of a patent foramen ovale. So this current recommendation, patients with PFO, according to the Society of Cardiovascular Angiography and Intervention, is to close the PFO in patients who had prior stroke and should be given on dual antiplatelet for 1 month, which we did for this patient, and should be maintained on aspirin thereafter. In conclusion, transesophageal echocardiogram still remains the gold standard in diagnosing PFO. However, intolerant patients can still be diagnosed using transcranial duplex ultrasound. And transcranial duplex ultrasound would offer a non-invasive alternative in patients highly suspected of PFO to establish the diagnosis. And PFO is considered if there is acoustic or visual detection of high-intensity transient signals in the middle cerebral artery during the first 3 to 15 heart cycles during contrast or agitated saline infusion. And closure of PFO is highly recommended for patients who have developed transient ischemic attack or stroke. Thank you.
Maybe I just ask. So, did y'all ever find out what happened to the ASD? Because that might confound the picture she was having.
I think the ASD was misdiagnosed, sir. They thought it was atrial septal defect, but all along it was already PFO. However, they were not able to interrogate this patient because during the time that each time the probe was inserted, the patient gets into seizures.
Do you have intracardiac echo, ICE, available? That would be another alternative way to image somebody who's intolerant of
Yes, sir.
TEE.
However, in our country, sir, it's not readily available, sir.
Did her migraines go away after you closed the PFO?
Yes, sir. It should have been closer, the PFO.
Did her migraines get better? That's another controversy in PFO.
Oh, yeah.
Association with the migraine headaches. It's interesting.
Yes, sir.
We have two moderators who are joining us remotely. Anything you want to add? I think Ken Chak and Sung Shi Sian. I think I can see them online. If nothing, then we should move on to the next.
Yes. Next case is combined antegrade and retrograde percutaneous closure of a perimitral pseudoaneurysm causing paravalvular leakage after mitral valve surgery. Dr. Prompinol Vichikalislip from Thailand, please.
Good afternoon, professors and audience, and thank you for the invitation. I'm Pornpimol Vichitchaisin, interventional cardiologist from Ramathibodi Hospital, Thailand. I would like to present the interesting case, combined antegrade and retrograde percutaneous closure of perimitral pseudoaneurysm causing paravalvular leakage after mitral valve surgery. I have no disclosure. So the patient was an 83 years old male, present with dyspnea on exertion with class 2 New York Heart classification. He denied having orthopnea or PND. He had history of severe MR and TR post minimally invasive MVR with Sorin 25 mm and tricuspid valve repair since 2016. He had post-operative complete heart block with atrial fibrillation, so he had pacemaker implantation. His physical examination revealed normal tension with a pansystolic murmur at the apical area, and he was consulted by a CVT surgeon for evaluation of recurrent post-operative severe MR. His EKG showed pacemaker rhythm, and his chest X-ray showed myocardiomyopathy with mild congestion. The echocardiogram demonstrates well-seated mitral valve bioprosthesis, no rocking motion, no oscillating mass. There was complex paravalvular regurgitation beneath the mitral valve at the medial side of LV. The flow directed toward the aneurysmal sac and continued to the left atrium. Another smaller PVL and aneurysm was found at the lateral side of LV. The CTA of heart showed multifocal aneurysm from the LV. The large one rose from the medial wall of the LV and a wide neck. Another two small aneurysm was found at the posterolateral side of the LV. Combined right and left heart catheterization was performed. The algorithm showed multiple submitral outpouching lesions with some contrast exacerbation to the LA. The LV-EDP was 7 mm mercury. The mean pulmonary arterial pressure was 13 mm mercury. No oxygen saturation step up, and the coronary angiogram showed non-obstructive CAD. So the patient was diagnosed with PVL with multiple complex submitral pseudoaneurysm. After heart team discussion, he has considered to have intermediate operative risk due to elderly, severe frailty, and previous thoracic surgery. His STS score for MVR was 2.8% and the Euro score 2 was 5.8%. We plan to perform percutaneous LV pseudoaneurysmal closure with device at the largest one at the medial side of LV, which had fistula into the LA, by combined intricate and retrograde approach. The interatrial septum puncture was performed successfully using ML1 and AKS needle. Then the artery catheter was placed instead. A 7 French guiding AL1 was clotted into the LV, and the Tolumo guide Y was able to cross into the aneurysm. Then we successfully deployed the Impulsor vascular plug to 9/12 mm in the aneurysm. The LV gram and TE performed afterward show a good position of the device with reduction of the flow from the LV into the aneurysm. However, there was some residual contrast to the LA. So we decided to close the fistula by the intricate approach. A 6 French guiding MP1 was crossed via the right femoral vein into the arteries catheter and placed into the LA. The guide Y was able to cross through the fistula into the aneurysm, and we successfully deployed the Impulsor duct occluder to 6/4 mm at the fistula. Then we performed the LV gram and TE that show a good position of the device without significant residual flow from the LV into the aneurysm and the LA. Another smaller aneurysm at the lateral side of LV, we plan to evaluate the CTA after 3 months. That showed 2 Impulsor device in the aneurysm and partial thrombosis with reduction of the size of aneurysm at the medial side of LV. And the lateral one is stable inside, no significant change. The patient had no symptom, and he had significant increase in exercise capacity. Take-home message: there is no standard approach for LV pseudoaneurysmal closure. Percutaneous left ventricular pseudoaneurysm closure might be challenging and feasible therapeutic option for a high-risk surgical candidate. The use of multimodality imaging and proper pre-procedural planning are the key to success. Thank you for your attention.
Is there any comment or question from online? Dr. Ken Chak-yu, so do you have any question on this case? We cannot hear you.
What about now? Can you hear me now?
Yes, It's not.
Okay, so congratulations on the very successful case. My question is, on these kind of very complex anatomy, how would you compare using a plug device versus some coiled device in closure of these pseudoaneurysm? Thank you.
We choose the size by the fluoroscope and TE guidance that the device, we choose that this device is compatible for the aneurysm and the fistula.
Okay, I think if there's no more questions, thank you very much.
Thank you.
And we'll move on to the last case, will be presented by Numfom Twitsani from the Chulabon Royal Academy in Thailand. And the case is about a pilot challenging study of early cardiac MRI following TAVR within 14 days.
Okay, thank you. Good afternoon, all participants. I'm Namphon Tuyasni. I'm a radiologist from Julapon Royal Academy, Thailand. Today, I will present a pilot challenging study of early 3 Tesla cardiac MRI following TAVI within 14 days in the term of safety, imaging quality, and long-term clinical outcome. I have no disclosure. Okay. As we know that CMR provides reproducible anatomical and functional information, but no declarable optimal timeline on both safety and clinical efficacy for immediate CMR following TAVI, despite of MRI safety approval. So we aim to assess safety, image quality, and long-term clinical outcome of using 3 Tesla cardiac MRI following TAVI within 14 days. This is our image. So we recruit 24 patients with CVAS underwent TAVI during November 2019 to December 2020. After TAVI, we used several products of the TAVI valve, and within 2 weeks, our patient underwent CMR and then long-term follow-up with echocardiogram during 6 to 12 months. We collect the MR-related heating parameters, LVEF by MRI, and we interpret imaging quality and MRI artifact and echocardiogram report. So let me simplify you about MRI-related heating parameters. There are several factors to create the heating to the patient. One is parameter of MRI sequence, and the second is the body weight of the patient. As we know that overweight or obese patients are higher risk for absorbing heat from MRI. So the heating parameter that you should concern is a 3 topic. First is SAR, or specific absorption rate. This is about the heat deposit in tissue by RF pulse and exposed per unit mass. It depends on the patient weight and the MRI sequence. And the second is the B1 plus RMS. It's the time-weighted average MRI effective and created by scanner during scan, and it depends on MR protocol. And the last one is SED, is mean the specific energy dose in joules per kilo. Is the total energy absorbed by patient during MRI. So we analyze descriptively fashion and compare to the standard value that accepted by IEC and correlate with heating from MR sequence and body weight. We collect the LVEF and imaging quality and MR artifact that rated by radiologists and MRI-trained cardiologists. And the last one is echocardiogram. We collect AVV MAC, evidence of AR and prosthetic AV valve function. So more than 60% of the patients are male, and the average is 18 years. The weight is about average is 57.6, but it varies from 40 to almost 80 kilogram. And average of the patient are in normal BMI. Only 3 patients has obese. But in our study, body weight and BMI are not associated with the heating effect in our study. It is the sequence that we perform in our patient in 8 sequences. And you know that total body time scan is only 3 minutes. Okay, but it varies due to patient condition. Okay, about the heating parameter, we found that okay. Okay, we perform CMR within 3 days to 30 days after TAVI. At average is 6 days. And the first value is SAR or SAR. The 3-chamber view is the highest value, but the average is 2.55. And the IEC and Medtronic MRI safety guideline is accept the maximal at 4 watt per kilo. Our study is just 2.55. And the second one is B1 plus RMS. The 3-chamber view is also the highest value, but average is like 2.01 microtesla. The acceptance is the most is 2.8 microtesla. The last one is SED. Total SED in our study in average is 416 Joule per kilo, but in the MRI safety guideline, accept the highest at the 14,000 Joule per kilo, and the short axis images that used for LVEF assessment is the most highest value. And no serious MRI-related complications were found and immediate after TAVI or follow-up in 1 year. About the imaging quality, or patient has good image quality in terms of image plane, anatomy, and function. No signal loss or wraparound artifact is found, and all are able to assess LVEF. The artifact, we found that metallic artifact in 100%, image blurring about 75%, and ghosting artifact is 33%, but not interfere image interpretation. About the long-term follow-up by echocardiogram, average of ABV max is 2.26, and we found that evidence of moderate AR about 2 patients, but it's proven to be TAVI-related complication, not MRI. And all the patient has normal prosthetic AV function. So the discussion point, factor affect MRI-induced heating in our study is scan time per slide and total scan time that vary due to patient condition. And body weight is not associated with heating effect in our study, but it was concerned that overweight and obese patient has higher risk for absorbing heat from MRI. And no serious complication found during scan, just 3 days or 30 days after TAVI and 1 year follow-up. So to conclude that, our first frontier pilot challenge study proved that 3D cardiac MRI within 2 weeks after TAVI is safe and sufficient image quality to assess LVEF despite of metallic artifacts. CMR could be carefully added to routine image workflow with more information and reproducible structural and functional cardiac evaluation. And factors that affect MRI-induced heating are scan time per slide and total scan time that vary due to patient condition. So optimization and tailor-made depends on the patient's condition and clinical equation. So thank you for your attention.
Any questions from the panelists or moderators? Can I ask what's the advantage of doing a 3 Tesla
Yes.
scan versus a 1.5 conventional MRI that most of us are more familiar with?
Yes, in our institute has only 3 Tesla cardiac MRI first, but in the MRI safety guideline, we can use 1.5 or 3 Tesla is safe for cardiac MRI after implantation.
Do you think you can recognize any leaflet thrombosis or thickening on this MRI imaging after TAVR?
Again, please.
Leaflet abnormality, thickening or thrombosis like that.
You mean, can I see the thrombosis after TAVI, complication from TAVI?
On the MRI imaging.
From MRI complication, in our patient have no complication after MRI. During MRI scan, no complication, no foul thrombosis or any abnormality.
I have one question. So you mentioned that the patient condition is related to the time or heating. So what is the specific patient condition to affect and then make a longer time?
Because sometime patient condition after post-operative period, he can stand still, and sometime the technician have to repeat the sequence for the image quality, but in the safety zone, because the MRI machine have a real time collect the heating parameters all the time that we perform. So it's not over the limit of the heating parameters.
Any kind of physical limitation like obesity or other some kind of things?
Obesity is just a higher risk for creating heating by the patient self, but we can adjust by other parameters, just such as protocol. Although we have a standard protocol for all patients, but the technologies that have 10 years experience in our institute has adjusted the protocol like tailor-made for the patient due to depend on the patient condition, but keep the image quality to interpret.
Okay, thank you.
Excuse me?
Yes, go ahead. Yes, go ahead, please.
In a very nice study. In addition to the heating issue, what other side complication did you looking for? Is that possible that the valve position will be changed after the MRI?
Okay,
Did you measure the valve position?
Yes, as we know that all of the cardiologists or interventionists fear for MI-related heating and after valve replacement, it can be the complication like myocardial infarction or thrombosis like this. But from the literature review and the research of the in vitro or in vivo research, it's proof that it's no heating or that concerning problem at all. Because the valve is like the high technology valve is come from titanium and it's not generate the heating like before we use the old valve on the old version.
Okay. Any more questions? If not, thank you very much. So I think if there are no more questions, we can close the session. And thank you all for attending. And thank you to my co-moderator and the panelists. Thank you, everyone.
Thank you.